couldn't be here. So I'll be talking about the fixed bearing uni. No point in belaboring the benefits as well as indications of unicompartmental. We all know that we are trying to do it as a resurfacing procedure and trying to protect the natural knee kinematics, hoping for a better rehab, less complications, faster recovery, and a normal feeling joint. But as it was mentioned, it is one, selection of the patients, two, the technicality of doing this procedure right are the two downsides which we need to understand. Are Indian patients amenable for AMOA? Having AMOA and uni? Absolutely yes. This is a study which we did at our institute, and you can see 2,500 patients who were undergoing total knee. When we looked at the Oxford criteria, you could see that almost 47% of these patients could have ended up with a unicondylar instead of a total knee. So yes, we have patients who you open and you see that you have an ACL intact, lateral is fine. These are the patients that we should try doing a uni in. As I said, the challenges, the main problem comes where if you don't accurately position your implants, you don't end up with good alignment, and if you don't balance these knees, this is where you end up with an early failure. So the early failure after a unicondylar in the initial 2-3 years is much higher as compared to a total knee, which causes a lot of anxiety in young surgeons in taking up unicondylar. Indications are very similar for all AMOA patients. It is indicated, but the only difference between a mobile bearing uni versus a fixed bearing uni is there is some extended indication of using a fixed bearing in a ACL deficient or a patient who has slight instability as compared to a mobile bearing uni where you need a good functioning ACL as well as an MCL. Rest of the indications are pretty similar. We talked about obesity, as Dr. Mulaji mentioned, and as this article also says, that obesity beyond a point is not considered by Western surgeons, but these are surgeons who do 40 to 50% of their load as unis. So if we are much less, but my recommendation would be to stay away from anybody who's more than 35-40 BMI. So the ACL deficient knee, this is a paper by Eng where they have clearly shown that if you have no clinical instability and your typical condyle wear is only in the anterior aspect, these patients, even if you have deficient ACL, so essentially you're looking at these older patients who don't complain about instability. So these are the patients where you can actually do a fixed bearing uni instead of a mobile bearing uni. And in Europe and UK, this indication has been taken even further, especially in the younger patients, where they have combined doing a unicondylar as well as an ACL reconstruction in the same sitting. This is by Sebastian Lustig, where of course these are small series and the follow-ups is less than 2-3 years, but there is a scope and surgeons are actually doing ACL reconstruction as well as the uni, provided the caveat is you should be able to balance them very well and align them very well. And here comes the role of robotics. So this particular paper was robotic uni with an ACL reconstruction where you cannot leave for any scope for not precisely doing the procedure. So these are our contraindications at my center. So obesity, again ACL deficiency, we haven't tried, though we do a fixed bearing robotic uni. Again, hyperextension is something that you cannot correct, and FFD more than 10 degrees has been mentioned. Anything on the lateral side in terms of trochlea or patella, we don't do. And again, osteoporosis because of the fear of fracture. In terms of design, what is the big difference between a fixed bearing and a mobile bearing uni? Fixed bearing is a non-conforming design. The bearing is fixed in the tibial base plate. Hence, if you don't balance these knees properly, the risk for edge loading as well as wear is much higher. That's how the concept of mobile bearing knee appeals to most surgeons, because here you have a highly conforming design. You have a mobile bearing polyene which moves along with the femur. Hence the low contact stress as well as less wear. But in terms of complications and in terms of causes for revision, the reasons why we revise a mobile bearing uni versus a fixed bearing uni are slightly different. The causes for revision are usually progression of arthritis in a mobile bearing uni if you leave the knee too tight. Meaning if you feel the knee is loose and you overstuff it with a higher poly insert, then the chances of overloading the lateral side become higher. On the other side, if you leave it loose, the chances of bearing dislocation are there, and you've seen Dr. Mulaji present. And aseptic loosening is also possible. The amount of wear that happens is very different in a mobile bearing uni from a fixed bearing uni. Fixed bearing uni is more because of edge loading, delamination. So the type of wear pattern is different. So they essentially present with polyethylene wear. But in a mobile bearing uni, the wear particles are much smaller, which end up causing aseptic loosening before the polyethylene actually wears out. So the indications why we revise a mobile bearing uni are progression of arthritis if you leave them too tight, bearing dislocation if you leave them too loose, and aseptic loosening. But on the other hand, for fixed bearing unis, it's mainly because of the loading pattern and wear pattern which leads to the revision. In terms of comparison of results, prompts and complications, there is not much difference between a mobile bearing uni versus a fixed bearing uni. Both have similar incidence. A few slides on robotics. So this is a AOA, Australian Orthopaedic Association statement, where they have seen some utility of robotics in uni and less in hip as well as knee. The reasons are very clear. We've all talked about why precision is important. You want better alignment, better implant placement, as well as good balance. So I essentially do only robotic uni and I have no exposure to fixed the mobile bearing uni. So it gives me a great ability to plan the surgery, very accurate in terms of our sizes, where you want to position the implant. Here you can see that we are able to nicely overlap the femur on the tibia without any error. Our ability to move the implant gives us the chance of balancing these knees very well and prevent edge loading, which is the main issue with a fixed bearing uni. Then you have haptic guidance and the burr, which gives you the ability to exactly achieve the plan that you've set. So these are examples of some of my patients. Then it begs the question, does introducing robotics makes a difference as compared to a manual uni? This is a paper that I found Nick Clement, who is greatly reputed for his randomized controlled trials and systemic reviews. So he looked at robotic versus manual, where he only looked at, instead of all types of robots, he only looked at Mako, which is the image based, and he looked at learning curve, precision, complications, PROM, and cost effectiveness. And here you can clearly see, because of the aid of technology, there is learning curve for time, but there is no learning curve in terms of achieving the target. So from the first surgery, the robot gives you the ability to precisely execute the target. But as compared to a manual uni, where it is highly commonly known now that unless you do more than 20-30 cases a year, you won't develop that finesse and precision and avoid these complications, which almost becomes a catch-22 situation. In terms of precision, again, compared to manual, the robotic unis were much accurate. In terms of complications, they haven't listed out the whole complications, but as such, the incidence in a robotic uni was much less as compared to manual. They looked at incidence of re-intervention, and they said that there were more re-interventions in the manual group as compared to the robotic group, but there was no difference in terms of PROMs income when you compare manual versus robotic. So the take-home message is UNICONDYLARs are much amenable to AMOA because they recreate your natural knee kinematics. They are technically challenging. That is the reason there should be some more precision should be involved. Fixed unis are different from mobile bearing unis. There are some extended indications for fixed bearing unis. In an ACL deficient knee, it can be done. The modes of failure for a fixed bearing uni are different from a mobile bearing uni. There is no difference in terms of clinical outcome when you compare mobile and fixed bearing, but there is a difference robotic versus manual uni, where you have no learning curve and you have better accurate positioning as well as ligament balance, but no difference in prompts. Thank you.